And then we'll go ahead and get started. Okay. 1 second. So thank you everyone for coming to our American Society of Onconephrology lecture series. So today's presentation is kind of going to be a highlight of some of the experiences of our onconephrology lectures. And so, so today is a highlight from Dr. Avinash Rao Ullur, who is a current onconephrology fellowship at the University Health Network in Toronto. And he's going to talk about some interesting presentations of an unusual diagnosis. So first, we'd like to thank our educational sponsor series sponsors, BTG Specialty Pharmaceuticals and Renibus Therapeutics. All right, and then I'll go ahead and give it to you, Avinash. Oh, you're muted, Avinash.
Are you able to hear me now? And is my screen visible?
Yep, that looks.
Sorry.
No, you're good.
Yeah.
Yep, perfect.
Okay.
Yes.
So sure. Again, thanks everyone for joining today's presentation, and I thank ASON Education Committee for giving me this opportunity to present some of the interesting cases that I encountered during my onconephrology fellowship. So mainly, I'll be presenting few interesting cases which are related to IgG4 related disease with different nephrological spectra. So giving a brief outline for today's talk, I have compiled 4 different nephrological presentations of IgG4 disease that I encountered in my clinic experience. So each case will be followed by a bit of discussion on overview of the disease, diagnostic criteria, pathogenesis, glomerular disease manifestation, as well as overall management and prognosis of such cases. So moving on to the first case, there was a 48-year-old gentleman who presented with relentless cough, anorexia, as well as significant weight loss. The initial evaluation was normal, and we went ahead with a CT thorax, which showed a presence of anterior mediastinal mass with left axillary lymph node enlargement. So this is a CT picture which shows an axial section with left anterior mediastinal mass, which is depicted by the arrow. So he did underwent a left axillary lymph node biopsy, which showed fibroinflammatory lesion indicative of fibrosing mediastinitis and thymic epithelial proliferation. At this point, there was no autoimmune workup done. As there was an undiagnosed inflammatory pathology, which was found in the biopsy as well as on the radiology, the team started the patient on oral steroids, and which was tapered over a few weeks. The patient was followed after 2 months with repeat CT and chemical shift MRI, which showed multiple enlarged lymph nodes at diaphragmatic, retroperitoneal, para-aortic, as well as in the supraclavicular regions. So to rule out malignancy, he underwent a bone marrow aspiration and biopsy, which was again negative for any kind of malignancy. So he underwent a repeat biopsy of left supraclavicular lymph node, which showed polyclonal lymphoplasmacytic infiltrate and follicular hyperplasia. This time he underwent an autoimmune workup, which was negative. His IgG4 level at this point was 0.55 gram per liter, with the reference range being 0.039 to 0.864. After a year or so, he presented to ER with acute kidney injury, secondary to obstructive uropathy. His creatinine from a baseline of 1.07 milligram per deciliter had increased to 2.01. He underwent a CT pelvis, which showed right-sided hydronephrosis with bilateral common iliac nodal masses confluent in the presacral space. Although he was offered a urological intervention, he did not consent to move forward. So again, he was followed up after a month with a repeat CT pelvis as well as thorax this time. And it was notable to see a recurrence of anterior mediastinal mass. So he underwent a biopsy of this anterior mediastinal mass this time, and it showed extensive collagen fibrosis. He was again given a course of oral steroid because of the prevailing confusion about the diagnosis. So this is the CT scan pictures of his anterior mediastinal mass obstructive uropathy on the right side, as well as confluent bilateral common iliac lymph node masses. So image 1 shows left-sided anterior mediastinal mass with mixed attenuation. Image 2 shows right-sided obstructive uropathy with discrete enhancement. And image 3 shows bilateral common iliac lymph node masses which are confluencing towards the midline and extending to presacral space. So this time he was referred to nephrology after a few months because the serum creatinine remained to be elevated at 1.7 milligram per deciliter. His 24-hour protein quantification at this point was 0.1 gram per day. He was off steroids 2 to 3 months prior to the referral. Repeat investigations were done wherein his complement levels were found to be normal, but immunoglobulin quantitation showed hypergammaglobulinemia with elevated IgG4 level to 1.4 gram per liter, with a reference normal being 0.039 to 0.86. So as the radiological, serological, pathological, as well as clinical features were consistent with the diagnosis of IgG4 disease, the patient was restarted on steroids. His creatinine reduced to 1.36 milligram per deciliter, and currently he's on a maintenance low-dose prednisone along with addition of mycophenolate mofetil. So with that, we will just see a brief overview of IgG4 disease. As we all know, it's a complex pathological condition with versatile manifestation in different organs. It's a fibroinflammatory condition with indolent course and a slow progression. The prevalence for now is unknown, but its recognition is growing worldwide. And it mainly involves patients who are middle-aged and older adults with male predominance. The incidence is mainly, the information on incidence is mainly from Japanese population, where the incidence is noted to be around 0.28 to 1.08 per 100,000 population. And there appears to be a genetic correlation in at least in Japanese population with a relation to HLA-DRB10404 and DRB10401 haplotypes. 15% of these individuals can present with renal involvement, and most of these patients will also have different other organ involvement. So there is a diagnostic criteria for IgG4 disease, which was put forth by Mahera et al. In 2020, which was revised over a previous diagnostic criteria from 2011. So this mainly consists of 3 items. Item 1 being clinical and radiological features, having one or more organ that show diffuse or localized swelling or a mass or a nodule characteristic of IgG4 related disease. Item 2 being the serological diagnosis with elevated serum IgG4 levels to more than or equal to 135 milligram per deciliter. And third being a pathological diagnosis with positivity of 2 or more of the 3 criteria. The first being dense lymphocytic and plasma cell infiltration with fibrosis. Number 2 being ratio of IgG4 positive plasma cells to IgG positive cells greater than 40%, and the number of IgG4 positive plasma cells greater than 10 per high power field. So the IgG4 positive plasma cells in high power field is varies between different organs. It's greater than 10 for meninges as well as kidneys, and it might be more than 100 for patients who have skin disease associated with IgG4 related disease. And the number 3 pathological diagnosis is a typical storiform fibrosis, which is more specific for IgG4 related disease or presence of obliterative phlebitis. So diagnosis can be definite, probable, or possible depending upon all these criterion. And there are organ-specific criteria as well. In case if a patient has a probable or possible diagnosis, the organ-specific criteria can help in making a definitive diagnosis. So coming to serum IgG4 levels, meta-analysis from 2016 of around 9 studies showed cutoff value of 135 to 144 milligram per deciliter, showed a sensitivity of 87% and a specificity of 83%. Just an elevation of serum IgG4 level is not sufficient for diagnosis. So it should be accompanied by clinical radiological features as well as the pathological features. So again, serum IgG4 levels can be disturbed by the prozone phenomenon. We may find normal IgG4 levels in patients who have IgG4 related disease as well. So we need to be very careful while interpreting the IgG4 levels in such patients. So coming to the organ-specific criteria for kidney disease, Seki et al. In 2021 have proposed this particular criteria, which is very much helpful in diagnosis of kidney disease with relation to IgG4 disease. So there are 5 different items in this. Number 1 being presence of some kidney damage as manifested by abnormal urine analysis or urine marker, or decreased kidney function with either elevated serum IgG level, hypocomplementemia, or elevated serum IgE level. Number 2 being abnormal renal radiological function. Third being elevated serum IgG4 level to more than or equal to 135 milligram per deciliter. Number 4, histological findings, and fifth being the extrarenal organ involvement. So again, there are definite and probable possible diagnosis even in relation with the kidney disease. So it is notable that in the histological findings, for the organ-specific kidney criteria, there should be a dense lymphoplasmacytic infiltration with infiltrating IgG4 positive plasma cells to be more than 100 per high-power field, and or IgG4 to IgG positive plasma cells to be more than 40%. This criteria has a sensitivity of 90% and a specificity of 90.1% in diagnosis of IgG4 related kidney disease. So almost all the patients with kidney disease have elevated IgG and IgG4 levels, and 40% of these patients may have elevated IgE levels. 60% of them may have profound hypocomplementemia, and positive ANA levels may be found in around 32% of the patients. We do not have specific pathogenesis to explain why the hypocomplementemia occurs with patients with IgG4 related kidney disease, but it is explained that even though IgG4 doesn't activate complements as such, the accompanying IgG1 and IgG3 can be active in causing the complement activation and leading on to hypocomplementemia in such patients. Coming to IgG4 related tubulointerstitial nephritis, which is one of the most common presentation of IgG related kidney disease. Mayo Clinic and Japanese Society of Nephrology have put forth some of the criteria to diagnose IgG4 related tubulointerstitial nephritis. And this is based on histology, imaging, serology, clinical features, as well as other organ involvement. And also in patients who are highly suspected to be having this disease, when there is an elevation of serum IgG4 level and IgE levels, as well as after ruling out pathologies like lupus and vasculitis in such patients. So we'll move on to the case 2, wherein we had a 74-year-old gentleman who presented with symptoms of fever, burning micturition, and left-sided flank pain. His creatinine at hospitalization was 4 milligram per deciliter, and his urine analysis showed large number of leukocytes with minimal proteinuria. With suspected pyelonephritis, after sending blood and urine culture, he was treated with IV antibiotics. His CT pelvis at admission showed left-sided hydronephrosis. With that, he underwent insertion of left ureteric stent, and his serum creatinine improved to 1.46 milligram per deciliter. A follow-up CT was done at 8 weeks, and it showed a regression of hydronephrosis with mild enlargement of retroperitoneal lymph nodes. With this improvement, his ureteric stent was removed. So he came to clinic after 3 months. He had an asymptomatic increase in creatinine to 2.5 milligram per deciliter. So with that, he underwent a repeat CT scan, from which we have the images today. So it showed perinephric mass encircling the left kidney. So the axial and the coronal sections of the CT, as we can see here, shows the perinephric mass, which is pointed by an arrow. And he then underwent a biopsy of this perirenal mass, which revealed a dense fibrosis with a plasma cell-rich lymphoplasmacytic infiltrate and focal obliterative phlebitis, which was suggestive of IgG4-related disease. So we did complement levels after that, which was normal. His autoimmune workup was negative, but again, his serum IgG4 level came up very high with a value of 1.5 gram per deciliter, and his total IgG levels were also high at 18 gram per liter. So he underwent a left ureteric stent insertion again, and he was started this time on oral steroids. With that, his serum creatinine improved to 1.92 milligram per deciliter. His ureteric stent was removed after 4 months. Currently, he remains on low-dose prednisone maintenance, but his serum creatinine is stable at around 9 milligram per deciliter. So with that, we come to pathogenesis of this IgG4 related disease. So as we all know, IgG4 itself is not very much active, or it doesn't take part in inflammation as such. Besides, it's known to be anti-inflammatory. It acts as an antigen sink in areas wherein there is an inflammation. So with that, it is mostly proposed or speculated that CD4 positive cytotoxic T cells may have the major role in the pathogenesis of IgG4 related disease. CD4 cytotoxic T cells basically secrete perforin and grazyme, which causes cytotoxicity. And they also secrete interferon gamma and TGF beta, which recruit fibroblasts, causing typical fibrosis in IgG4 related disease. And there may be a role of T follicular helper T cells, which can secrete interleukin 4 and 10, which can cause differentiation of plasma or the B cells to short-lived plasma cells, which can secrete the immunoglobulins. And these particular plasma blasts or the B cells can continue to activate CD4 cytotoxic T cells with presentation of autoantigens, keeping them active and causing more fibrosis. So the typical pathological features of IgG4 related disease are represented in these pictures. So the main pathological features include dense lymphoplasmacytic infiltrate, second being a typical storiform pattern of fibrosis, and third being obliterative phlebitis. Some of the patients may have phlebitis without obliteration of the vessel lumen, and some of the patients may have increased number of eosinophils in their histopathology. So the figure A represents a dense lymphoplasmacytic infiltrate with storiform fibrosis from a pathology specimen from a mediastinal fibrosis. And the figure B represents a higher magnification of the same image, with black arrows showing storiform fibrosis and white arrows showing lymphoplasmacytic infiltrate. And figure C is from a biopsy from a retroperitoneal fibrosis, where we can see a black arrow showing confluence of IgG4 positive plasma cells. And figure D is a specimen from, again, mediastinal fibrosis, wherein the vessel is occluded by obliterative phlebitis. So moving on to case 3, we had a 59-year-old gentleman who was referred for evaluation of nephrotic range proteinuria. So his past medical history was significant for a sarcoid myositis, which was diagnosed in 1994, and he was treated for prednisone for some time. At presentation, he was not on any treatment. His urine analysis showed 4+ blood and 3+ protein at evaluation, and a 24-hour urine protein quantification showed a proteinuria of 3.9 gram per day. His serum creatinine was 0.9 milligram per deciliter, and his GFR was 98 at presentation. Further workup for complement levels were normal, and his ANCA profile revealed presence of anti-MPO antibodies to a titer more than 8 AI units, with a reference normal being less than or equal to 0.9. His X-ray, which was done then, showed linear opacities in the bilateral lower lung zones, and which was further evaluated with a CT thorax, which showed reticular fibrosis in bilateral lower lung lobes. And with that, with the elevation of ANCA titers, we suspected the patient might have ANCA-related vasculitis affecting the kidney. For that, and also to confirm the nephrotic range proteinuria, he underwent a biopsy. His kidney biopsy showed presence of membranous nephropathy with mild interstitial fibrosis and tubular atrophy with no features of vasculitis, interestingly. And his immunofluorescence was negative for plateau or staining, but it was positive for IgG with trace amount of IgG4. And his electron microscopy then showed electron-dense deposits on the thickened basement membrane. So his muscle biopsy from 1994 was reviewed after that, and there was an inflammatory myopathy with necrotic fibers showing infiltrated by lymphocytes, and there was endomysial fibrosis and some perivascular lymphocytic infiltrates. but it was not having any granuloma to show any evidence of sarcoidosis. But then there was no staining done for IgG4. So with this information, we went ahead doing an IgG levels and with a subclass quantification, which showed elevated IgG4 level of 2.02 gram per liter. So with all the information available with pathological, serological, and the radiological features depictive of IgG4 disease, he received ARB and also oral steroid. We started him on induction oral steroid. So with that, he improved well, and his nephrotic range proteinuria reduced. As he was steroid dependent, we switched his therapy to rituximab, which was given 1 gram every 6 monthly. And with this maintenance rituximab, his proteinuria has remained stable at 0.5 to 0.7 gram per 24 hours. So key take-home points from this particular case is that in the IgG4 related glomerular disease, membranous nephropathy is one of the most common presentation, which is seen in around 7 to 10% of these patients. And there are a few case reports with IgA nephropathy, membranoproliferative disease, as well as endocapillary proliferative diseases seen in patients with IgG4 related kidney disease. Nephrotic range proteinuria is one of the prime manifestations, and it is speculated that IgG4 antibodies recognizing carbonic anhydrase 2 with consequent exposure of mitochondrial neoantigen could be playing a role in multifactorial pathogenesis of IgG4 related membranous nephropathy. So as we saw in this particular case, there was a positive ANCA titers. So it has been seen that in 1 in 150 patients with IgG4 related kidney disease, the ANCA vasculitis can overlap with IgG4 related kidney disease itself. And in such cases, it has been noted that there will be a low titer of ANCA rather compared to high titers as in ANCA vasculitis. The pathogenesis is again suspected to be secondary to some reactive oxygen species activity, or it could be related to some genetic factors, but it's still unknown. And high titers of ANCA again does not correlate clinically with the disease activity in such cases. So recently I came across this particular table from Modern Rheumatology, which was published very recently by Cavano et al. So this gives a beautiful table differentiating between IgG4 related kidney disease from ANCA associated vasculitis. So mainly in ANCA associated vasculitis, we can see high titers of ANCA as well as elevated CRP levels, which would be usually of low titers in IgG4 related kidney disease. And response to glucocorticoids is very good in IgG4 related kidney disease, which differentiates it from ANCA related vasculitis. There could be multiple other organ involvement which can be seen in IgG4 related kidney disease, which would not be present or it would be rare in ANCA related vasculitis. And coming to histopathological findings, necrotizing vasculitis, granulomatous lesions, and neutrophilic infiltrates would be more particular to ANCA related vasculitis rather compared to IgG4 related kidney disease. So the last case, this was a case of a 78-year-old asymptomatic gentleman who was referred to myeloma clinic for evaluation on suspected myeloma. So his past medical history included a query diagnosis of IgG kappa NGS since 2017, and he had a CKD diagnosed since 2017, and at presentation it was of stage 4, and there was no etiology which was specifically found out for the CKD, and he also had benign prostatic hypertrophy, DVT, and glaucoma. He was using temolol drops, tamsulosin, and apixaban at presentation. Giving a brief history of his IgG kappa NGS, which was detected in 2017. His investigation then showed serum protein electrophoresis, which was depictive of a large increase in gamma fraction, and there was a possibility of hidden M proteins then. His immunofixation showed elevated serum IgG, IgA, and IgM levels. His FLC ratio was elevated to 6.57 with increase in kappa fraction as compared to lambda. His bone marrow, which was done in 2017 as well as repeated in 2021, showed normocellular marrow trilineage hematopoiesis with less than 5% polyclonal plasma cells, and it was negative for amyloid. His skeletal survey and 24-hour urine protein were normal. Regarding his CKD status, his baseline creatinine trended between 2 to 2.5 milligram per deciliter between 2017 and 2022. His kidney biopsy, which was done in October 2021, showed more than 50% sclerosed glomeruli, and it had severe interstitial fibrosis and tubular atrophy. But again, interestingly, it showed dense infiltrate of plasma cells, which by immunohistochemistry showed monotypic kappa staining with a ratio of kappa is to lambda being 10:1. So at the initial visit, his hemoglobin was 11.6, his corrected calcium was 2.4, and creatinine was 2.5. We had kept a differential of possible granulomatous disease such as sarcoidosis or presence of tuberculosis and infectious causes such as histoplasmosis. And also we suspected there could be presence of an extramedullary plasmacytosis. So with that, we ordered a PET CT, which was done in August 2022. It showed a mild FDG avid opacity in left lower lobe, and rest of the findings were normal. His serologies for histoplasma and tuberculosis skin test were negative, and his ACE levels were normal. With that, we also kind of, with this results, we suspected maybe this patient has an IgG4 related disease. We did an IgG4 level in him with subclassification, wherein his IgG levels were elevated as previously, but again, his IgG4 levels came out to be around 1.91 gram per liter, which was highly elevated. So as the PET CT showed mass in the left lower lobe of the lung, we did a CT thorax to confirm that, and we found there was a 2 centimeter focal consolidation mass in the left lower lobe of the lung, as depicted in the CT with an arrow. He underwent a lung biopsy to diagnose the specific etiology of this lung lesion, and this depicted an atypical plasma cell population with background storiform fibrosis, which was consistent with IgG4 related disease diagnosis. So with that, he was treated with steroids, and we are still to assess the response with the therapy. So key take-home points from this particular case is that several conditions may mimic IgG4 disease in various multidisciplines, including hematology. So protein manifestations could be lymphadenopathy in 30 to 60% of the patients, eosinophilia in 40% of the patients, and polyclonal hypergammaglobulinemia in these patients. The serum free light chains tend to be abnormally elevated in such patients, and hypergammaglobulinemia can be mistaken for polyclonal increase in IgA and could be confused with MGUS or biclonal IgG kappa and lambda gammopathy. Some of these patients may even be treated for myeloma with prevailing confusion, and multi-organ involvement may be a clue in such cases to diagnose IgG4 related disease. So this is a slide on some of the mimickers of IgG4 related disease. Autoimmune conditions like ANCA vasculitis, sarcoidosis, Sjogren's disease can mimic IgG4 disease, as well as malignancies such as adenocarcinoma, squamous cell carcinoma, inflammatory myofibroblastic tumors, and lymphoplasmacytic lymphomas can also cause confusion in the diagnosis with relation to IgG4 related disease. Other diseases such as Castleman disease, cutaneous plasmacytosis, as well as inflammatory bowel diseases can also kind of mimic IgG4 related disease and may cause discrepancies in management. So coming to the treatment part, in patients with probable or definitive diagnosis of IgG4 related disease, it is suggested to start prednisone at a dose of 0.6 milligram per kg with a maximum dose of 40 milligrams per day. And the treatment response needs to be assessed in 2 to 4 weeks after starting the therapy. In case there is a good response, it is suggested to taper down steroids in 3 to 6 months time. And the response needs to be assessed clinically, radiologically, as well as with biochemical markers. And in case if the patient had multi-organ disease or substantially elevated serum IgG4 levels at presentation or a history of relapse from previous disease, it is suggested to maintain the treatment with low-dose prednisone with or without addition of azathioprine, MMF, CNI, or cyclophosphamide. In case a patient does not respond to initial induction treatment with steroids, it is suggested to consider B cell treatment with rituximab, the dose being 1 gram given for 2 doses in 15-day intervals. Uh, in some of the cases, such as renal thyroiditis, aortic aneurysm, or in patients with ureteric stenosis secondary to retroperitoneal fibrosis, surgical options could be a consideration. There are few case reports stating a role of abatacept, dupilumab, and bortezomib in a few of these patients with IgG4 related disease. And recurrence of IgG4 related disease could be treated with steroids or steroid sparing agents depending upon the previous treatment and the adverse effects. So this is the treatment algorithm for IgG4 related disease as a whole. And most of the evidence for use of prednisone in IgG4 related kidney disease comes from series by Japanese Society of Nephrology as well as Mayo Clinic. And evidence for use of B-cell therapy comes from Mass General Hospital. And in that particular series, 97% of the patients with IgG4 related disease responded to rituximab, but there were only 4 patients with IgG4 related tubulointerstitial nephritis. So, the evidence for B-cell therapy in such cases is still to be investigated more. Lastly, regarding the prognosis of IgG4 related disease and IgG4 related kidney disease, by now we know that the natural history of this disease is not very well known, and it's still an indolent disease and has a very long progressive course. And the complications of IgG4 related disease can include chronic kidney disease, pancreatic insufficiency, retroperitoneal fibrosis, liver cirrhosis, and malignancies such as gastric cancers and lymphomas. And IgG4 related kidney disease shows a rapid response to steroid treatment, although we may not achieve a complete response with the treatment. Even with maintenance treatment with steroids and other agents, it is seen that 20% of these patients may have a relapse of the kidney lesions. And in one of the series with 40 patients with IgG4 related kidney disease, it was seen that 60% of these patients at follow-up with repeated CT scans had renal atrophy, even in patients who responded very well to the initial induction treatment. Again, coming to the transplant perspective, there is a case report of recurrence of IgG4 related tubulointerstitial nephritis post-transplant after 5 years. So to conclude, IgG4 related disease is a poorly recognized entity with varied spectra and involvement of different organs. Diagnosis of this particular disease is based on characteristic pathology along with serological, radiological, and clinical parameters. And pathogenesis, as we discussed, it's still poorly understood, and we need more evidences to explain why this happens. And glucocorticoids are the standard induction treatment for now, and but we may encounter adverse events with relation to steroids, particularly in elderly population. And B-cell therapy appears to be promising, but requires further investigations. And early recognition and treatment of IgG4 related disease would prevent progression of the disease and multiple complications. Thank you all for patient listening, and I acknowledge Dr. Melvin Silverman, Dr. Avijat Kichlu, and Dr. Christine Chen for their contributions to the case as well as suggestions. So now the house is open for any discussion and questions.
Yeah, that's great, Avinash. I'm impressed that you've seen so many cases of IgG4 related disease in your short time there. I think I just saw my first case the other day, and I think it's really interesting that you noted in your first case that the IgG4 levels are only elevated in about 40% of patients. And so this guy, he had basically like a retroperitoneal mass encasing his ureters and aorta. No one could biopsy it. His IgG4 level repeatedly was negative, and they decided to treat him with prednisone, and it got better. So, which was really nice to see. So I think I guess the specificity of the IgG4 level would be very high, but the sensitivity is pretty low. Is that fair?
Yes.
Yeah.
I would say yes, although it's said that overall in general IgG4 related disease, the IgG4 levels are having a sensitivity of around 83% and a specificity of around 87%. But the recent organ specific criteria for kidney from the Seki et al., which was published in 2021, they show that the sensitivity has kind of increased, at least for kidney, to around 90%. So yeah. if we use that particular criteria, we might be able to catch up more patients.
Got it. And then I'm more interested in your last case because, I think a lot of patients would probably, or a lot of people would see that case and think, oh, maybe this is like some sort of monoclonal related kidney disease. And so what tipped you guys off into checking IgG4 levels or really kind of thinking that maybe this wasn't all related to paraproteinemias?
Initially when this patient came to our clinic, we also didn't have any clue why this is happening because he did not fit into the criteria of myeloma diagnosis. So that's the reason why he was referred, and he was known to have this increase in kappa levels and the increase, the free light change to around 6.5 even since 2017. So for further evaluation and management, he was referred to us. Probably, I would say the major clue that we had in this patient was the lung mass which we detected. So probably the multi-organ involvement would be the best clue to detect IgG4 related disease rather than just relying upon the serology levels.
Yeah, because I mean, obviously the IgG level, total levels were elevated, but I don't think
Yes, it
routinely
was
someone would
elevated from
get the,
previous.
yeah, IgG4 levels. So I think that's really interesting. A lot of these patients actually get treated, right? So, um, um,
Yeah.
and so I guess my last question is too, so at your institution, who is kind of championing thinking about these diseases? Has it kind of come from rheumatology or from the hematologist or kind of, where do you in your diagnostic algorithm now think about IgG4 related disease?
I would say in our institution we involve multidisciplinary team in managing such patients because even though if we detect the case or if the other teams detect the case, there will be definite involvement of rheumatology as well as nephrology in patients who have kidney dysfunction to give their contributions to manage the case. So I would say multidisciplinary team involvement is very much essential in managing such cases.
Well, that's great. Um, well, I appreciate your time and effort into this. So good luck. Where are you going to after this?
I've not yet decided. Probably I'll be continuing for a few more months, but yeah, yet to
Uh,
decide.
All right. Well, that sounds good. Well, good luck to you in the future. And thank you again for your time.
Thanks so much.
And then have a good day, everybody.